lectures coming up. On Thursday, March 22nd, we will welcome Dr. Damien Shea, professor in the Department of Biological Sciences at North Carolina State University. His talk, Reducing Chemical Risks to Families, Linking the External Chemical Exposure to Biological Effects and Reduction in Adverse Health Outcomes, will take place in the Life Sciences Lab, room S340 at 4 p.m. Also, Michelle McDowell, a researcher from the Max Planck Institute of Human Development, will give a talk on Knowing Your Risks, the Effect of Information Representation on Risk Literacy. And that talk will take place on April 10th at 1 p.m. right here. Our speaker today, Dr. David Grabowski, will be introduced by 2017-18 Family Research Scholar Dr. Ning Zhang. I would first like to introduce Dr. Zhang. She is the assistant professor in the Department of Public Health, School of Public Health and Health Sciences. She received her BS in Business Administration at Nanjing University, her MS in Economics, and her PhD in Public Policy with a concentration in Health Economics and Policy from Cornell University. Her research focuses on obesity, long-term care, health services research, and health economics. Dr. Zhang is currently working on a proposal to study quality care issues of long-term stay nursing home residents who are obese. Please help me welcome Dr. Ning Zhang.
Thank you, Giselle. It is my great honor to introduce Dr. David Grabowski as the Tay Gavin Lecture Series Speaker 2018. Dr. Grabowski is a professor of health policy in the Department of Healthcare Policy at Harvard Medical School. He is a nationally and internationally well-recognized health economist and health services researcher in aging, long-term care, and policy analysis. His research examines the economics of aging with a particular interest in the areas of long-term care and post-acute care. His work also examines the integration and coordination of care for dually eligible beneficiaries. Dr. Grabowski has been the principal investigator on 5 R01s from National Institute of Aging, and I have to mention how difficult it is of obtaining an R01 from the NIA. The funding line is like 8th percentile, so how difficult it is. And his projects are related to the value of post-acute care, skilled nursing facility payment, demand for long-term care insurance, specialization in dementia care, and nonprofit provision of nursing home care. His research has also been supported by a number of private foundations, including the Robert Wood Johnson Foundation, the Commonwealth Fund, Arnold Foundation, and the Donahue Foundation. Dr. Grabowski also led a team at Harvard in the evaluation of a CMS nursing home value-based purchasing demonstration. Dr. Grabowski has published more than 100 publications and on very prestigious journals like New England Journal of Medicine, JAMA, Health Affairs, Health Services Research, Medical Care, to just name a few. He was the 2004 recipient of the Thomason Prize for Young Investigators from the Association of University Programs in Health Administration. Dr. Grabowski received his BA from Duke University and his PhD in Public Policy from the Urban Harris School of Public Policy at the University of Chicago. His talk today is Opportunities and Challenges Using Market-Based Approaches to Encourage High-Quality Nursing Home Care. Let's welcome Dr. Grabowski.
Great. Well, first of all, thank you to everyone at the Center for hosting me. Thanks, Giselle. Thanks, Angela. And special thanks to Ning for inviting me. We had a great time today talking about her research. Really, really promising work in a really, really important area. So I very much enjoyed it. I hope my comments and feedback are helpful, but more importantly, I look forward to seeing your work in this area for many years to come. It's really great stuff. So it's really great to be here. I want to kind of talk to you a little bit about my work and the work of others. Really, that's part of this revolution we're having in terms of how we pay, how we regulate, how we oversee nursing home services in this country. I was recently, this academic year, appointed to the Medicare Payment Advisory Commission, or MedPAC. It's a bipartisan commission that advises the Congress on issues around Medicare payment. And one of the things we hear a lot on that commission is we want to move from paying for volume to paying for value. And we have a long history in this country of paying for volume, for hospital services, for physician services, and also for nursing home services. And we're seeing this shift to more value-based payment models. And this presentation is really about that kind of shift in nursing homes. We're moving from a paradigm of regulating quality to one where we're trying to create a market that encourages high-value, high-quality nursing home care. And so I'm going to do four things with my time today. First, I'm going to give you a little bit of background on the U.S. nursing home market. Ning and I spend a lot of our time thinking about this market. I appreciate others in the room don't, and so I wanted to take a few moments to just level set and give you some background on what this sector looks like, who receives care here, and then I want to talk about this issue of low-value nursing home care. We have a lot of individuals in this country that aren't receiving care that's really of high quality, and we're spending a lot on those services. And so I want to talk about that misalignment or that disconnect. And then I'm going to talk about three different market-based approaches to encouraging higher value, higher quality care, and then I'll conclude with some takeaways from my talk today. You should feel free, I don't know what the kind of the norm is, but to interrupt with questions or comments, or can we say it in the end, but I'm happy if you have anything that you want to ask as we're going, just put your hand up, and I'm happy to answer questions. Let me start with just some background on the market for nursing home services. So it's quite large. We spend over $150 billion annually on nursing home services. That's a big number on kind of a societal level. What about on an individual level? Well, it's also quite expensive if I'm paying out of pocket. A semi-private room can run in the Boston market well over $100,000. Even in other parts of this state, $80K, even for just sharing a room with another resident. The probability of use over one's lifetime is actually fairly high. If you think about an individual age 25, they have just over a 1 in 4 probability of entering a nursing home at some point during their life. If you look at an individual age 65, almost a 1 in 2 probability that you're going to end up in a nursing home. Today, about 1.6 million individuals live in about 16,500 nursing homes nationwide. 16,500 sounds like a big number. I used to use the comparison, there are more nursing homes in this country than McDonald's. We all know that we're all eating healthier, McDonald's are closing, so that's no longer a good comparison. So my new comparison, there are more nursing homes in this country than Starbucks. That should really have an impact, because there's a Starbucks in every corner, there's a nursing home on every corner. This is a large, important sector in this country. Most of us have a particular person in mind when we're thinking about a nursing home, and I just wanted to make this point because it's going to come up several times throughout the talk today, that there's incredible heterogeneity within the nursing home population in terms of the residents. But in general, we tend to group residents into two particular types. There's the type that I think that we're all familiar with and has been there for decades, and that's that chronically ill, long-stay resident. Many of these residents have dementia. They're receiving assistance with activities of daily living, like bathing and dressing and toileting and walking. They're likely going to be in that nursing home for the rest of their life. And their care is predominantly financed by either Medicaid, and you have to meet state income and asset thresholds to qualify, or they're paying privately. By paying privately here, I mean largely paying out of pocket. There's very little private long-term care insurance in this marketplace. There's a second group that's really grown over the last 20 years, and that's these post-acute short-stay residents. So these are individuals who are discharged from the hospital. They have a 3-day qualifying hospital stay. Maybe they had stroke, a hip fracture, pneumonia. They need some therapy in a nursing home prior to being discharged back, usually to their home. This care is financed by Medicare. Maybe the average length of stay is 25 days, so it's a relatively short stay. These groups receive care alongside one another. In most U.S. nursing homes, there's relatively little specialization. Most nursing homes do kind of both types of care. And there's obviously some cycling in that many short stay patients unfortunately transition into being long stay residents. They don't get discharged back to the community. And then many of those long stay residents are hospitalized for different issues and then come back in the nursing home as a post-acute resident on the Medicare benefit and then transition back to Medicaid or private pay. I'll say this now, and this will come up again later, but Medicaid is thought of as a less lucrative payer relative to those individuals that are paying privately, and also that short stay Medicare payment. Those are thought of as the more desirable payers by nursing homes. I want to make the point that there's a real disconnect here between what we pay and the quality of care that we often get. So expenditures are growing quite a bit in this sector. You can see this just traces and projects out through 2019, total nursing home spending, and then also what's the Medicaid share there, and what's the Medicare post-acute share. They're all growing. I didn't show this figure, but I have another figure where the Congressional Budget Office has projected this out a couple of decades. Given the aging baby boomers, we're just going to see an explosion here. This market is not going away. We've tried to transition a lot of individuals out of nursing homes, but every projection that I've seen suggests we're going to see increasing expenditures. We may be able to decrease on a per-person basis utilization, such that we could lower the overall rates of utilization, but just the sheer numbers of aging boomers is going to lead to increasing utilization at the societal level. What about, so in spite of us spending a lot on services, quality of care has been a long-standing problem. Most of the quality of care problems have been focused on that long-stay population, but I think many of us have argued that there are also quite a few quality of care problems on the short-stay, post-acute side as well. There's a large academic literature. Obviously, Ning is contributing to that literature. Our team has done a lot of work. Academics around and other researchers around the country have really built a large literature. There have been New York Times and other media reports of poor quality. The General Accounting Office and OIG and others have done a series of reports. The Institute of Medicine. I include this book on the left here by the late Bob Kane and his sister Joan West, titled "It Shouldn't Be This Way: The Failure of Long-Term Care." Really powerful book that I highly recommend. Bob wrote kind of broadly on issues around nursing home quality and long-term care quality. This is a book about the care of his own mom. In the first chapter of the book, she's living independently in Florida. In the last chapter of the book, she dies in a nursing home, and he kind of traces how the long-term care system fails her at every sort of stage, chapter by chapter. Because Bob knows the policies, because he knows the clinical side of it, he's really able to put that in a great context. I want to make the point, his sister was their mother's primary caregiver. She was very involved in her care. His mom had some private resources, and she obviously had Bob, one of the experts in the country on long-term care. In spite of all those advantages, information, money, involved family, she still had a terrible experience. So it's something to keep in mind. I'm going to tell you a lot today about different market-based innovations in nursing home care, and suggest that maybe we can change how we spend the money here, to change how we deliver the information, the systemness that we have in this marketplace. But we are facing some real challenges here. This is just to connect the 2 points I just made, one around spending and the second around quality, and that's to say that it's not just a problem for individuals living in nursing homes, but rather because they're receiving relatively poor quality, that isn't just reflected in pressure ulcers and pain and use of physical restraints and other poor quality measures within the nursing home. It also translates to transitions to the hospital, and thereby puts a burden on the Medicare program. You can see this is the rate of potentially avoidable nursing home hospitalizations state by state. You can see that the rate is actually coming down a bit from 2010 to 2015, but still quite high. And the states there that actually have the abbreviation are ones in which CMS is doing some innovative programs in right now. But you can see that the rates of potentially avoidable hospitalizations are quite high, and this kind of cost shifting from kind of the nursing home setting to Medicare program is really important and something I want to come back to later in the talk. So how do we sort of think about this? I'm an economist. We have this very kind of, I call it very rigid, but we have this way of looking at the world and modeling the world. And every student, and many of you have probably been in this class, Econ 1, we have this very nice model of how the world works. And we have prices set in the marketplace based on the intersection of supply and demand. And we have this ability of firms to enter and exit that marketplace freely. And we have well-informed, if not completely informed, consumers. And we have this well-coordinated system of care that when I make investments, those impact the outcomes and spending in my part of this system, but don't have these sort of negative externalities or negative spillovers for other parts of the system. That's kind of the standard model that we have. What about the U.S. nursing home market? It actually deviates from all of those ideals that we put up in the standard economic model. Prices aren't set in the market, they're set administratively. What I mean by that is outside of those private paying nursing home residents, Medicare is setting the prices, and for the most part, for most nursing home residents, Medicaid is setting the prices. What about free entry and exit? Well, in most states, we have what are termed certificate of need laws. We have such a law here in Massachusetts, where in order to build a new nursing home or expand an existing nursing home, you actually have to go in front of the certificate of need board in the state and show a need for additional beds. It's not going to shock anyone in here that existing nursing homes have a strong incentive to keep supply down. It gives them kind of a monopoly here. And so the CON boards have often been reticent to allow these marketplaces to expand. And so in many ways, this impedes kind of free entry and exit and innovation in this marketplace. I'm going to come back to this issue and talk more about it later, but suffice it to say that these are not the kind of well-informed, rational consumers we think about in Econ 1. Huge rates of cognitive impairment, a lack of family, the need to make decisions in real time very quickly. This isn't something you can plan months and months ahead for. These consumers, these residents and their families aren't often very well informed. And then we know that the system is incredibly fragmented here. And I just showed you an example of that we pay for nursing homes here, hospitals here. And so nursing homes underinvest, for example, in clinical management or services. That impacts nursing home outcomes and nursing home spending, but it also impacts hospital spending and hospital outcomes. And vice versa, when hospitals discharge residents to nursing homes sicker and quicker, that's going to have implications for nursing home quality as well. How do we sort of deal with this issue that we have this very different marketplace with very different types of consumers? Historically, we've relied on regulation. And there's a saying out there, I've never gone out and actually counted the pages of regulation, but nursing homes are apparently the second most regulated sector in our economy. Anyone want to take a guess at the first? Nuclear power. So it's very different, strange bedfellows there, very different industries, right? With very different products and everything. It's odd to think of nursing homes as being mentioned in that same body with nuclear power. So we've relied a lot. We have regulation after regulation. And I'm not trying to say that some regulation isn't good in this sector, but I'm trying to say that I don't know that more regulation is productive here. I think we've kind of reached that point of diminishing returns. And so a lot of policymakers, researchers, advocates have suggested that we really try some new approaches here to improving performance in this sector. And I want to talk about the kind of research and the idea around three such approaches. The first is paying for performance, and I'll talk about some of the work we've done and others have done on this. Second are publicizing quality information, so making report cards available where you can tell the quality of different nursing homes in the market and potentially lead consumers to make better decisions. And the third are ways in which we're not just paying for nursing homes separate from hospitals, separate from physicians, but rather trying to pay more globally for care and what impact that's had on care coordination, on outcomes, on spending. So let's start with pay for performance, or P for P as it's often known. It's a very, very simple idea. It's near and dear to economists' hearts. Rather than paying for volume or paying for services, as I mentioned earlier, why not pay for good outcomes? And we can pay more for nursing homes, for example, that prevent hospitalizations or have higher staffing or lower deficiencies or better pain management or fewer physical restraints. And so we can think about all sorts of different quality metrics entering into a formula and ultimately rewarding those providers that do better. It can be that we pay them more, or we have a quality withhold and you only get your money back if you meet that threshold. So there's definitely different ways to design P for P, but I think the intuition here is relatively straightforward. As with any policy, there's real potential for unintended consequences. And I like to think about, you often hear economists talk a lot about unintended consequences. I like to think about this like a drug. A drug has its intended effect, but it also has side effects. And with this policy, the intended effect here is to improve performance, to improve quality. But oftentimes we have to deal with these side effects, with these unintended consequences. And there's real potential here in designing P for P that if we start paying more for quality, maybe nursing homes start avoiding those sicker residents if the risk adjustment formula isn't adequate to account for their care. Maybe they only pay attention to those rewarded measures of quality and ignore those unrewarded measures. Maybe only the best nursing homes are able to respond to this, and so it widens the gulf or the gap between those haves and those have-nots. So we have to really be careful about these unintended consequences when we're thinking about whether P for P actually works. I want to go through a few of the ideals that we have for a well-functioning or well-designed P for P system. I would offer these 6, and this is based on kind of a larger set of papers in the literature. The first is I think, pretty straightforward, but fundamental and often violated by P for P programs. There needs to be a clear link between my effort as a provider, how that then links to better performance, and the formula or the score that they're using to reward or punish us, then ultimately my likelihood of that receiving that reward payment. If any of these links are broken, you can imagine that providers aren't going to invest in quality improvement, aren't going to invest in the program. And just to take you through this, let's say one of the measures in a P for P system for nursing homes is avoiding potentially avoidable hospitalizations as a potential measure. How do I do that? How do I go about? Do I hire a new staff member? Do I introduce a new kind of protocol or procedure here in the nursing home that allows me to prevent those hospitalizations, that ultimately then allows me to have a better performance score, which ultimately translates into that reward payment? If there's a disconnect there, you're not going to invest. The second ideal, they have to be meaningful reward payments. One of the jokes, and it's not that funny, but I'll tell it anyway, is like P for P, it's supposed to stand for pay for performance. There's often this criticism that P for P stands for pennies for performance. And so that's what P, see, no one laughed, it wasn't that funny. Now you're giving me a sympathy laugh, thank you. Pennies for, so we see this with a lot of P for P programs that are out there. They pay literally cents on the dollar, and so there's no incentive to invest in additional staff, changing how we deliver services, because there's not enough money on the table. The payments have to be immediate. Anyone that's ever tried to use any reward structure with kids understands this one. You can't tell them you're going to get the trip to Disney World in 2 years. You're going to get the new teddy bear in 4 weeks or something. It has to be relatively immediate. I've been a part of P for P programs where we've delayed the payout almost 2 years. By that point, there's no feedback loop. There's no kind of learning. They've even forgotten what they've done. There's no incentive to kind of invest further in the program. There needs to be this elimination of any external factors influencing whether I receive a reward payment. I'm going to tell you about a program, the NHVBP, the Nursing Home Value-Based Purchasing demonstration, in a moment that I worked on, where the program had to be budget neutral in order for there to be a payout. So I not only had to be the best performing nursing home, but I also collectively, with all the other participating nursing homes, had to show savings relative to these comparison nursing homes. My likelihood of a payout doesn't just depend on whether I do good, it depends on whether all the other participating nursing homes are engaged in doing good. They're saving money. because I alone can't generate enough savings to get a payout. That kind of incentive, those external factors is going to lead to nursing homes just checking out and deciding, I don't want to engage in this program. A big economic literature in education, in healthcare suggests that if we want to generate improvement, it's not enough to just give incentives. You have to give education, you have to give guidance. I'll use the example of hospitalizations of nursing home residents. Do nursing homes know how to safely prevent those hospitalizations? Some do, but I think many don't. And if you want them to reduce those types of hospitalizations, you need to show them best practices. You need to give them a roadmap for how to do that. And then finally, and I won't belabor the point because we already talked about it, you want to minimize those unintended consequences like selecting healthier residents and avoiding those sicker ones, or only paying attention to those rewarding measures. So I'd like to talk about 3 different nursing home P4P models. All have been published. So the first was this nursing home value-based purchasing demonstration. I was involved. This was a Centers for Medicare and Medicaid Services, or CMS, evaluation that we worked on with L&M Consulting. The second is some work on state Medicaid programs. Many states have adopted P4P models. This is work by Rachel Werner at the University of Pennsylvania and colleagues. And then I was involved in an effort led by Greg Arling. Greg's now at Purdue. We worked with the state of Minnesota to evaluate a very different kind of pay-for-performance program. I would consider the 2 programs on the left, the NHVBP, and many of the state Medicaid programs, very typical P4P programs. The PIP program that I'm going to tell you about in Minnesota, very different, but it actually, here's a spoiler alert, it's the only one that actually shows any return in terms of quality. And so it very much turns on its head a lot of the kind of tenets of a traditional P4P program. So let me first tell you about the NHVBP. So this was a 3-year voluntary CMS demonstration. First, the states had to volunteer, and we actually had 4 states that stepped up. The 3 states you see listed there, Arizona, New York, and Wisconsin. Mississippi also volunteered to be a part of the demonstration. And they ultimately didn't get enough nursing homes in Mississippi to participate, and so they dropped out. And then within those states, we had to have individual nursing homes step up and volunteer as well. You can see ultimately we had 38 nursing homes in Arizona in the demonstration, 72 in New York, and 61 in Wisconsin. And I'll make an important point that you'll see play out over the next couple of slides. Only in New York, we had wanted to randomize in all 3 states, and so these facilities would volunteer, and then we'd sort some into getting the payment demonstration, some would just be paid in the usual way. They would be the comparison group. Only New York did we have enough kind of nursing homes step up and volunteer. It's a bigger state than Arizona and Wisconsin, so we had 143 nursing homes volunteer, 71 are in the comparison group, or randomized to the comparison group, 72 to the treatment group. Arizona and Wisconsin, we had to construct Apt Associates, that was the implementation contractor for CMS, constructed a comparison group in that state. Nursing homes were rewarded both on absolute performance and also quality improvement from baseline. So the baseline period was the year before, July of 2008 through June of 2009. Nursing homes were evaluated on 4 performance domains, so staffing, both levels of staffing and staffing turnover, survey inspections or deficiencies, a series of quality measures taken from the minimum data set, or MDS, like pain and pressure ulcers, and physical restraints and functional improvement, both short stay and long stay quality measures, I should note. And then finally, we had both short stay and long stay hospitalization measures. And once again, those top performing nursing homes in each state and each year, so each state and year were on their own kind of bucket here, their own bottom. There was no kind of combining of states or years. So we looked at 9 separate experiments, basically, 3 states times 3 years. And you only received a payout as a best performing or top performing nursing home if collectively all those treatment facilities showed savings relative to the comparison nursing homes. So those 72 nursing homes in New York had to show savings relative to the 71 facilities for those best performing nursing homes in New York to get a payout.
Excuse me,
Oh, yeah, sure.
was there third-party verification of these performance measures, or were they largely self-reported?
Yeah, great question. And this is a broader issue with quality measurement in the sector in general. So let me start. Hospitalizations are taken from Medicare claims data, so those are definitely verified. The quality measures are taken from the minimum data set. The minimum data set is self-reported, so that definitely is susceptible to the issue that you're raising. Survey inspections are done by a CMS surveyor that comes in roughly annually, so that we would think is an objective measure. The most interesting one here, that's why I went backwards, is staffing. So historically, we've had nursing homes self-report staffing. CMS was very worried about exactly the issue you're pushing at, that are we sure that's going to be accurate? They also wanted to capture turnover of staff. And so they made all the participating nursing homes submit payroll data so that we could actually see kind of what was the turnover, what were the levels. This isn't going to surprise you either. When we did a separate comparison of those rates relative to the rates that were being self-reported, these rates were lower than what nursing homes have been self-reporting. So I think it was a really good investment by CMS. I'll say now that all the data that's reported on the CMS website is from payroll-based data. They've gone completely to payroll. The nursing home sector doesn't love that, but I think it was a really good investment.
And what about selected admissions? Do you have any way to monitor that?
So I'll show you our results in a moment.
Okay.
We did not find a lot around big quality improvements, so we've argued that there wasn't a lot of sort of gaming going on here. There weren't a lot of, we don't seem to be observing a lot of intended consequences, so we don't think unintended consequences were a huge issue, but it's certainly something that we had planned to look at. We just didn't find big effects on the intended side, and so I don't know that we would have seen that on the unintended side.
I just don't see how you measure that, I guess.
Yeah, I think you have to look at kind of whether you're seeing big changes in case mix, relative to the treatment, sort of the case mix, acuity at admission, are there particular payment categories, are there particular types of patients that they're avoiding? So we had planned this whole series of analyses to get at unintended consequences, and I guess I'm giving away the punchline here. We don't see a lot. Yeah, thank you.
So which nursing homes were in this programs? Are they systematically different or systematically identical?
We did a lot of work sort of on external validity here and whether these nursing homes are generalizable. So first, are these 3 states, do they look like all the nursing homes in all the other states? There's some differences. Arizona has been very innovative on the Medicaid side. New York is a big, wealthier state. Wisconsin has been relatively innovative. I think it would have been really nice to have Mississippi here. It would have added, not just some geographic variation, but just a different kind of state to this demonstration. I think within these states, yes, it was nonprofits were overrepresented to some degree. But we were able to match on that, and obviously in the randomization, this didn't affect internal validity, but you're right, certain kinds of nursing homes were more likely to sign up. Other than having to submit the payroll data, they weren't at risk for anything. Some of them, I don't want to give away my punchline here, but some of them were actually received payouts, even though we don't think they did a lot. So I think there was an advantage to actually joining the demonstration, which I don't think a lot of them realized a priori. So let me give you these results. I've already sort of teased these. We looked at a lot of measures, all of the domains that I just put up there, staffing, and survey inspections, and lots of quality measures and hospitalization. We didn't see any impact. I mean, it was really pretty staggering. And not even to mention, all the comparisons we made, we would have had to adjust for multiple comparisons. Even just treating each of those independently, we couldn't find kind of statistically significant results, and just no pattern in the results. It just really didn't seem like much was going on there in performance. So what about on spending? Here I've written kind of mixed or no impact, or well, which is it? If you just look at the data and take it at face value, this is what CMS found when they calculated savings. They actually found in year 1, they found some savings in Arizona relative to the comparison nursing homes, and some savings in Wisconsin, no savings in New York, and then in year 2, they did find some savings in Wisconsin. And so there was a payout to those best performing nursing homes in Wisconsin and in Arizona, at least in years 1 and 2. So that suggests maybe this worked, and if it saved money, even if it didn't impact quality, that could be a good thing, right? So I don't know if I mentioned this earlier, but this was a mixed methods evaluation, where we did a lot of qualitative work talking to participating nursing homes. And so we went out and we talked to a number of facilities in all 3 states. almost to a facility, we asked, what did you do? Kind of how did you respond to the nursing home value-based purchasing demonstration? We heard a lot of nothing, not much. We didn't do anything. In fact, one of my favorite responses, we said, we're here from the nursing home value-based purchasing demonstration, and the respondent said, what's that? There's such turnover in leadership and administrators at these nursing homes. I think they have so many fires they're putting out, and they're just doing a lot that this was not in their kind of on their radar screen. Go ahead, yeah.
Well, I was just going to ask, how can they save money here? So they prevent hospitalization, they have shorter stays.
So they can prevent hospitalization, they can look better on their quality measures, they can have fewer survey deficiencies, they can have more staff relative to those comparison groups. So even if they're showing improvement, if they're looking good, as long as there's savings, and the savings is about preventing hospitalization.
Okay.
Sorry, it's about ED visits. We look broadly at spending.
Okay.
So it was a broad measure of spending. And once again, remember, New York was the only state, once again, that we randomized it, and we didn't see an effect, and I'm going to come back to that point in a moment. So we heard this. I want to tell this quick story. It's kind of funny. My favorite response wasn't the one I just mentioned. We talked to one of the nursing homes in Wisconsin that got a relatively big payout, and it turned out it was a religiously affiliated nursing home, and we said, what did you do? And they said, well, we lit a candle every night. Really not what CMS had in mind when they designed this program. It was a little disheartening as a group that put a lot into this evaluation. But once again, keep in mind with New York, no impact on spending there. And this led our team to go back and really push at these results to look at what was going on here. And what we found in New York is that when you randomized in that baseline year, so this is looking at spending for long stayers, but I could have done this for short stayers, it turned out the treatment group was relatively similar to control, even a little bit lower. So it's just overall Medicare spending per long stay resident day. So this impacts hospitals' inpatient spending, all their post-acute, all their Part B, it's all in that measure. Look at this though, what happened. We didn't match on baseline spending in Arizona or Wisconsin. So when APT went and constructed, I'm not blaming them, this is just sometimes the way propensity matching goes. When you didn't adjust for baseline characteristics, it turned out in Arizona and Wisconsin, spending just happened to be much higher in those treatment groups relative to the control groups. So when you had this regression to the mean, when these two kind of calibrated, nothing to do with the demonstration over time, what looked like savings was really just kind of normal fluctuation across the two groups, regression to the mean. So it turned out CMS in 3 of these 9 years mistakenly paid nursing homes thinking they were showing savings when really they had just done a bad job kind of matching them at baseline. So they weren't too happy with us when we reported this back to them. I think it's really important from a design perspective. So that's all I'm going to say on the NHVBP. Other than I do want to summarize how it looks relative to those different ideals we put up in a few moments. I wanted to go through first just what the lay of the land on what do the state Medicaid pay-for-performance programs look like. 10 to 15 states have tried these programs. I talked to one of the designers earlier this week. Indiana is revamping their program, and so she and I were talking about some of what they're doing there. So states are continuing to innovate in this space. This is a quote from Becky Griesacher, who was formerly at UMass Medical and now is at Northeastern. She did an early review of these programs and termed them mostly short-lived, that they varied considerably in performance measures and pay incentives, and evaluations have been rare. So Rachel Werner and her colleagues tried to address that gap in the literature by looking at kind of what's out there between 2001 and 2009 in terms of different programs. You can see here the programs that they looked at: Colorado, Georgia, Iowa, Kansas, Minnesota, Ohio, Oklahoma, and Utah. And here across here you can see kind of the different measures that were included in these programs, from bladder catheterization, physical restraints, pain, falls, pressure ulcers, unexplained weight loss, regulatory deficiencies, and different staffing measures. So kind of quite varied programs across a range of states. And what Rachel and colleagues did in their analysis was basically do a differences in differences, where they compared outcomes in states that adopted P4P relative to those other 42 states that didn't. And they found no consistent effect of these programs on different outcomes like staffing. They actually found deficiencies worsen, which is kind of hard to believe, but maybe some sort of unintended consequence, and then they found real mixed results in terms of those different QMs. hard to chalk up that this was a success here, these different state-based programs. The final P4P program I wanted to talk about is just very different. Some don't even like categorizing this as P4P, but I think it's so innovative and different that I really want to talk about it in this context. This is the Minnesota Performance-Based Initiative Payment Program, or PIP, which was established in 2006, and basically puts on the table $18 million roughly of new spending every year for nursing homes to use towards quality improvement projects. This isn't a pool of money that nursing homes can win by performing better. Rather, it's a pool of money that nursing homes can get by proposing a program to the state, either by themselves or with a group of other facilities in the state because they're commonly owned, or maybe just they come together for this project. And the projects are time limited, 1 to 3 years in duration. And the state kind of chooses some programs and rejects others. And they get 80% of the funding up front for the project. And the remaining is the sort of performance-based aspect of this. 20% of the dollars are withheld. They only get those if they achieve the project objectives. The projects look very, very different. You know, they can be about preventing falls. They can be about, pain. They can be about, prescription medications. You name it, hospitalizations, culture change. Quite varied in terms of what they're focusing on. But we found in our health affairs evaluation led by Greg Arling that in the pre-period, performance, in the PIP in red versus those nursing homes without PIP looked pretty similar. When it was introduced, they began to separate in terms of performance. This is just a quality indicator score that Minnesota uses. A higher score is better. And you can see that was maintained there in the post-period. So really encouraging results. And keep in mind, that's a global quality indicator. And those participating nursing homes had very specific quality, focuses. So imagine a nursing home doing a falls prevention program still look better in terms of their overall quality. Now, one of the things people have pushed on me about this program is why isn't this just a big income effect? They're getting these dollars into why is this P4P? Why isn't this dollars? And I think there's something to that argument, but I really believe that this withhold that they have, it really makes it kind of more performance-based and incentivized. And I'll say that very few times has the state had to actually not pay out that withhold. And that's maybe not surprising, right? There's a real incentive for these nursing homes to invest here because they propose the projects. So I wanted to come back to whether these different types of programs met the ideals that we laid out earlier. This link between effort, performance, and reward. No, in the case of the NHVDP, I think the participating nursing homes had no idea how they improved their scores. I think it's generally pretty poor in the state Medicaid programs. But PIP, it was very clear to them what the objective was and what they had to do. What about the size of the rewards? I think they were quite small oftentimes in NHVDP and many of the states. In PIP, there were real dollars here that they were working with. What about the role of external factors? No, in the NHVDP, sometimes in the state Medicaid, but there was no, you were the only set of nursing homes participating in PIP. The payout was immediate in PIP relative to the other programs. Remember, they get 80% of the funding up front. And then there's this issue of whether they educate or guide the nursing home. PIP definitely was doing that, and that they were working directly, the state, with the different participating nursing homes. So PIP looks a lot better. So the final thing I wanted to do with P4P is show you a program that CMS has now implemented and has in place today, and that's the SNF Value-Based Purchasing Program. It was part of the Protecting Access to Medicare Act in 2014. And basically, it pays nursing homes, and I'll show you the formula on the next slide, based on just on one measure, and that's their 30-day all-cause readmission measure. That's a National Quality Forum, NQF, measure 2510. And the way the program works, it's all incentivized around SNF readmissions. There's this 2% withhold, and then if the nursing homes perform well based on this measure, 50 to 70% of that gets returned, and some of the SNFs in the program can face up to a 40% decrease. So 40% of all SNFs face this payment reduction. So there's quite a bit of money at play in this kind of model. They've simplified it quite a bit from the NHVDP that I was a part of. So one lesson here is that we've learned a lot from how we've designed some of the earlier P4P programs. It's certainly not the PIP. It's much more on that traditional model that we were talking about. But I think there's a much clearer link here. You decrease your readmissions, you get a better performance score, you get your dollars back from CMS. There are a lot of dollars on the table. There's no external factors here. There is this lag in terms of the administrative data that needs to be collected and sorted out and figured out who are the good performers. But no guidance or education of the participating members. And I think here where this program could be really problematic, and back to your earlier comment, unintended consequences are really important here. When you have really blunt policy instruments, like we're going to pay more if you prevent those 30-day readmissions, they pay attention, SNFs pay attention to this, and they might decide we're not going to admit these kinds of patients, and we'll admit those. We're really going to pay attention to this and shirk on other measures. What about measuring mortality as a censoring event here? That might be really important. So I think paying attention to unintended consequences here is going to be really important when researchers go to evaluate that program. So I'd like to shift gears and talk about report cards in much the same kind of way that we've been talking about pay for performance as another market-based way of addressing low-value nursing home care. I made this point earlier that many nursing home residents lack the ability to kind of ascertain and ultimately monitor quality of care. That could be because of the high rates of cognitive impairment. It could be because they don't have family. That's often why you end up in a nursing home in the first place, because you don't have that family support structure and network in place. And obviously something's changed. You've had a stroke, a major health event that causes you to potentially need to enter a nursing home. This isn't buying a house or deciding on a college or other major life events. This is done very quickly and under a lot of stress. Report cards are a way to kind of address the quality problem here. They're based on an old sort of premise in economics, going back to the work of Ken Arrow and George Akerlof. They can sort of fix this disconnect between quality and choice. They can also obviously reduce the search costs, and then rather than having to visit all these places or as many places, maybe I can go on the web and cut down on the number of potential places in my choice set. There's, once again, real potential for unintended consequences. I want to look good on a report card and the risk adjustment isn't adequate. Maybe I avoid, once again, those sicker residents. Maybe I lower quality on measures that aren't reported on the website. And once again, maybe this could cause some widening between those haves and have-nots in the marketplace. What about the ideals or tenets of a good report card system? It should be well utilized by stakeholders. I can't tell you how many report card systems we have up that nobody seems to click on. This was a problem in the early years of Nursing Home Compare. It's like the tree falling in the woods. If it's on the website and nobody's clicking on it, is it really moving the needle in terms of quality improvement? It needs to be easily interpretable by stakeholders. That sounds really what's good, simple and straightforward. It's actually not, and I'm going to show you an example of that in just a moment. It's got to reflect true quality. It can't be that the measures on there are collected with a lot of error, or they're not appropriately adjusted for case mix, where I can't make apples to apples comparisons across nursing homes. And once again, I want to minimize those unintended consequences. This is a timeline of the Nursing Home Compare website. It's kind of rollout. It started in October of '98. The early generation of the website basically had, I think, deficiencies on there and kind of information about whether the nursing home was for-profit or non-profit. Nurse staffing and nurse aid data were added in June 2000. Those were the self-reported data. Today, now on Nursing Home Compare, they actually have the payroll-based measures. The big innovations really started here in 2002. That's where all the MDS-based quality measures were put on there as part of the Nursing Home Quality Initiative, and that's really where a lot of the research started on this website. Initially, it was launched in 6 pilot states, and then it went nationwide in November of that year, and then we've added some additional measures. And I'll note that kind of the major innovation here was in December 2008, where they actually moved from reporting all the individual quality measures to reporting a composite measure, making it a 5-star system, where 5 stars means this is a good quality nursing home, 1 star means this is a poor quality nursing home. So this is what the early generation, the NHQI website looked like. Probably can't read it, probably don't want to read it. It's really a mess. Like this, I've been studying nursing homes we've been for 20 plus years. I don't know how I'd choose between this nursing home and another nursing home based on these numbers. It's just, these aren't really useful. You can see they have like percent of long-stay residents who have moderate to severe pain, percent of long-stay residents who have pressure sores, percent of short-stay residents who have delirium. I think a lot of these measures are more about case mix than they are about quality, so that's my first comment. My second is that, so they don't really approximate true quality, but imagine you're looking at two kind of nursing homes, and this one looks a little bit better on pain, and this one looks a little bit better on pressure ulcer, and how do I sort of aggregate these up and actually make a choice? And they show me the national average, and they show me the average in Massachusetts, but I don't know how useful this is. This just seems like too much information for most individuals trying to choose a nursing home. Some of the early work looking at what impact the release of this nursing home quality initiative, this NHQI, had on quality. You can see that some measures, like physical restraints, were going down. Same thing with pain. Others, like infections and worsening of ADLs, look relatively flat. Hard to conclude whether these were just trends or whether the NHQI that's right there in the middle actually did anything here. And so a later set of studies, including some work I did with Bob Towns, some work that Susan Liu did, and some work once again by Rachel Werner and colleagues, tried to construct a comparison group so it wasn't just this pre-post trend. And Susan exploited, some states had state report cards before the NHQI was adopted, so she exploited states with and without an NHQ report card and what impact that had on quality. Bob and I looked at pilot versus non-pilot states. So remember those 6 states that launched in April versus the rest of the country that launched in November. Then Rachel and colleagues exploited the fact that for the post-acute measures, many nursing homes don't do a lot of that care, so they didn't have to report their measures. So she exploited this idea that there's this threshold. There were some nursing homes just above the threshold with quality scores and some just below it without. And so she used that as her way of distinguishing those with and without report cards. Susan found no effect on quality. Bob and I found no effect on quality. Rachel actually found for those post-acute patients that there was some increase around the NHQI. And this may make some sense in that, remember, those post-acute Medicare residents are the residents with kind of the strongest, sort of the most demand responsiveness. They're sort of the most savvy consumers. So one might expect that those are the ones that are most responsive to quality measures. She found some unintended consequences in that quality measures that weren't reported on the MDS actually decreased. Susan found some of that as well. That's a hard story to tell. You can find any intended effect. She finds some unintended effect. That's a really bad policy, by the way. It'd be like taking a drug that doesn't lower your blood pressure, but does, make you nauseous or something. That would be a drug I wouldn't want to take for very long. So, it's suggestive here with these report cards that at least with that early generation with the NHQI, we didn't really have many of the, they weren't well utilized. Many people didn't know about the website. Really hard to interpret all those measures. I've already argued, I don't know that we were actually approximating quality here, and lots of potential, as Rachel showed, for unintended consequences. So in 2008, we went to this 5-star system. You can see now that this is a well-known nursing home in Boston, Spalding Nursing and Therapy Center in the north end there. You can see, at least for this period where I did this screen capture, they had an overall rating of 5 stars. They also get a rating for health inspections and staffing and then quality measures. And then I can click in and see all the individual quality measures beneath that. But there's something very nice about seeing this. Marion Manor, another well-known Boston area nursing home, was a 4-star. And then you can see their different measures for these domains. Unfortunately, it's been very hard to find that comparison group to evaluate the 5-star. So we haven't seen quite as much work on this. But I will say, 5-star has really caused a lot more individuals to use the website. Nursing homes hate it because they don't think it's a good measure of quality. They don't like people using it to choose. They don't feel like it fairly represents the quality. But people are using it. It's very easy to interpret. 5 is better than 4 and so forth. Does it approximate quality? I don't think the nursing homes believe it does, but there's been some work suggesting yes, other works suggesting no. So I think that's kind of an open question. I think, once again, this is another policy that's very susceptible to unintended consequences. Final point, we're going until what time?
Until 1:45 if you want.
Yeah,
questions.
perfect. So I want to make a few more thoughts and then wrap up. So that's perfect. I wanted to say the final point I wanted to make. I talked earlier about the fragmentation in our system. I think all of this, whether we're moving towards P4P or a quality report cards, we want a kind of a nursing home financing and delivery system that emphasizes person-centered care, that delivers high-quality care for residents, and ultimately is well coordinated with other parts of our long-term care and healthcare system. And if you think about the typical nursing home resident, they're not just receiving nursing home services, they're also receiving physician services, they're being hospitalized, maybe they're receiving some therapy, at some point maybe they need hospice. Medicaid or private sources are covering their long-stay nursing home care, right? But any of those other services I just mentioned, whether I go to the doctor's office, whether I go to the hospital, whether I come back on the Medicare benefit, is covered by Medicare. And so what I've argued is that there's this connection between Medicare and Medicaid, or Medicare and private here, where how that nursing home chooses to invest in services in the nursing home is going to have implications for spending and outcomes in other settings in our system, and vice versa. How Medicare invests in those different systems is going to have implications for outcomes and spending in the nursing home. One of my favorite quotes, every system is perfectly designed to get the results it gets. Unfortunately, our current health and long-term care system for older adults around nursing home care is perfectly designed to achieve higher total costs and worse health outcomes. We have this perverse incentive for individuals as they get sick in the nursing home setting, for example, to be transitioned elsewhere. I've done a lot of research on hospitalization of nursing home residents in the system. The minute there seems to be a problem, send them down the street to the ED, where they're often admitted for an inpatient stay. That makes your job easier as a frontline staff. There's liability concerns, and plus, if they stay in the hospital, they come back to your nursing home on the Medicare benefit, which is higher paying. So all good things. Now, obviously, we're starting to incentivize nursing homes about hospitalizations and readmissions, but at least historically, we haven't had a good way of kind of controlling that problem. There's obviously few incentives for anyone to worry about overall quality across these settings and to manage or coordinate services. A number of programs are coming online, and you've probably seen a lot of these programs. There's PACE, Program of All-Inclusive Care for the Elderly. We have a program here in Massachusetts, SCOs, or Senior Care Options, programs in Minnesota and Wisconsin. CMS, including the program here in Massachusetts, is doing the Financial Alignment Initiative, which tries to bridge Medicare and Medicaid for dually eligible individuals. And then we have the Special Needs Plans, or SNPs, which are a special type of Medicare Advantage plan directed at special populations. And some of these have really tried to be fully integrated across Medicare and Medicaid. The idea behind all of these is, can we bridge these two payers up high such that they coordinate services across all these different settings on the ground? So there's sort of a good news, bad news here. I'll start with the good news. The two most rigorously evaluated programs, and I think we're seeing this again in some of the more recent evaluations of the Financial Alignment Initiative and also the SNPs, suggest that they're actually improving, or at least health outcomes look like they're stable, maybe even getting better, and we're seeing increased access to care. But relative to the control group, the bad news there on the right, spending has actually gone up, and so some of this maybe makes sense. It's really hard to do this well. It's often viewed as this, we're looking for this proverbial win-win, and that we want to both improve outcomes and access, yet also cut spending. That's really hard to do, it turns out. If you really want to manage care well for this population, maybe you need to spend a little bit more. And that's true whether in either the PACE evaluations by APT or Mathematica, or the evaluations of Minnesota. These were sort of the most rigorously evaluated of those early programs. So final slide, and we can open it up for any final questions. We can have cookies or something here, or both. I think nursing home policy is one of the most challenging, I think, areas in our healthcare system, just given the needs of the patients, the strong role of Medicaid, kind of some of the information issues we've talked about, regulation. I just think that this is going to continue to be a really challenging issue. I'm glad, Ning, you're working on this, and I hope you'll continue to work on it, because we need a lot of smart young people doing good work in this area. I would assert, I think regulation has been important in this sector, but I don't know that more regulation is the answer. I think we need to target what are the root causes of the problem. I think they're the way we often pay for services, the way that we provide information and try to address via those issues. However, I'm the first to acknowledge, I think, that many of it's been based on my research. I don't know that existing P4P and report cards have been that successful. And I would assert that design really matters here, how we sort of put these programs in place. And the final point is that in thinking about those designs, can we think about innovations at the system level? And the kinds of programs, we shouldn't always expect that they're going to save money, but I think we can expect that they're going to provide a more person-centered model, higher quality, and ultimately thinking about value not just in terms of spending, but also in terms of what we're getting for those dollars in the system. I'll stop on that point, put up my Twitter handle and my email if someone wants to get in touch with me. I'm happy to take any questions. Either. Who wants to go first in the back? Yeah, sure.
So you talked about regulation, but it does seem like the elephant in the room is liability. We're talking about lowering costs and one of the, in terms of transferring to the ED.
Yeah.
So have there been reforms, or I can imagine that in fact costs associated with legal liability have actually gone up?
Yeah, so that's a great question. So my colleague formerly at Harvard, now he's at Vanderbilt, David Stevenson, has done some really nice work on this liability, sort of exploiting some of the state-by-state differences in some of the policies here. And I do think it's been an important issue. I don't think it explains all of the hospitalizations, though, and that I think some of the quality, I do think it's a concern. I think nursing homes have actually made a lot of steps towards creating limited liability corporations and really trying to, I do a lot of research. Another thread of my research is really all the sort of creative ownership structures and all the integration and all the ways that nursing homes have responded to some of the issues around liability. So I think some of this they've responded to, but I don't know that liability alone explains, for example, the high rate of hospitalization. I do think it's a concern, but I don't know that these nursing homes are worried about getting sued. I think they'll, if a family member asks to have somebody transferred or a resident transferred, they'll do it. I think they'll talk to the physician. They'll go ahead and send them down the street to the emergency department. I don't think that's ever been the issue. I don't think that at the core. I think it's much more about staff wanting, feeling overwhelmed. I think there's been some real issues around payments and trying to. I think some of these other explanations are stronger, at least on quality. But I do think this liability issue is an important one. Just maybe not an area where I think we could probably get there. Liability reform would be important, but I don't know that it would be first on my list of reforms here for this sector.
There's serious trade-offs.
Yeah. Oh, absolutely. You had a question?
First of all, thanks for a really great and very informative overview. I'm just a little puzzled with all the emphasis on kind of the incentive structures. There doesn't seem to be much analysis of industry structure, for-profit versus non-profit, or large franchise versus small enterprise. It just seems like the incentives would be very different across those.
Yeah, absolutely, and hard to do everything in one talk. So.
Yeah, okay. So
invite me back and I'll give that talk.
But I would be interested in some references if you have some.
Yeah,
then
no,
I'll try to talk to you about it later.
Oh, absolutely. So I'll say a few words now. We can pick up afterwards as well. We've done a lot of research on this. It is the case that nonprofits tend to provide better quality than their for-profit counterparts. So there's definitely that. I think we do have to recognize nursing home nonprofits are very different. In that in hospitals, you tend to think about them as these safety net hospitals. These are often the best nursing homes. They have higher private prices than for-profits. They have more private paying residents. They're often religious affiliated nursing homes, so they look very different. When I first started studying this, I thought the nonprofits would sort of carve out this kind of, they would be a fine quality, but they'd sort of be on this low price end of the market and taking it. No. They're the glass chandelier places. They're the nicest nursing homes in a lot of these markets. And it's sort of upside down. The chain issue is very, very interesting as well. We do have these chains. There's been a tremendous amount of churning. We did a manuscript on this. I'd be happy to share, where we just showed that it was hard to establish that it was causal, but just all of this sort of acquisition and divestiture of these nursing homes. And it was just, 1 in 10 of these chain-owned nursing homes was being turned over every year. It was clear those were the lowest quality nursing homes every year that was sort of flipping.
Yeah.
And it wasn't the case that they were, the deal itself was causing them to be lower quality, but rather just something about these places, they were just being flipped and flipped. And that, so it definitely wasn't causal, but it was associative with this. And I think a lot of that, we've seen all of this private investment and private equity interest in this, a lot of separation of the real estate from the management in a lot of these nursing homes. Fragmented ownership structure, some of it for liability issues, some of it because I think some of these private equity groups just thought this would be a good investment. And we haven't found that quality has dipped along a lot of the measures that I've talked about today, but just some real concern that when you start sort of turning over ownership here, is that going to lead to kind of quality of care problems downstream? And there's a real lack of transparency. Today, if you go on Nursing Home Compare, you can actually see who owns the nursing home, and they've tried to get much better about showing you investors and all the kind of associated measures behind the ownership. But it's taken a lot of work to get here, and a lot of us telling them that there was a real lack of transparency for consumers and advocates and others that wanted to kind of compare nursing homes. The final thing I'll say, and with all of these integrated payment models and alternative payment models that are coming on, a lot of us have wondered whether we're going to see increased vertical integration where hospital systems are going to be buying kind of post-acute and nursing homes and kind of investing elsewhere in the system. And we did another health affairs paper just last year that looked at kind of whether investors, so healthcare investors, kind of had ties to both hospitals and different kind of post-acute facilities. And we found a huge growth over the last 10 years, kind of going from 10% to almost 50%. And so there's definitely a common investment ownership across the two. And that's something to monitor as well about, why a hospital might be discharging patients to a particular nursing home on the post-acute side. So, are there other, oh yeah.
Yeah, I kind of want to follow up because I was also interested in the for-profit versus not-for-profit, but then also those other entities, which are these continuing care retirement communities, which also sometimes have nursing homes as part of their structures. And just wondering how, again, sort of going back and analyzing the data using those various structures, how.
Yeah, those CCRCs or continuing care retirement communities are really interesting models. So we would see in these data the nursing home part of the campus, but then the independent living, the assisted living are typically off of our radar screen unless we have kind of some way of linking them in through Medicare claims. I have a colleague at Brown, she did something very innovative. She found the zip codes of these large assisted living communities and actually tracked them in Medicare claims, where now she can assign you to an assisted living community based on your zip code. And so she was able to sort of use this innovative method to kind of match individuals into assisted living communities. But it's been really hard unless we were working with the assisted living community. But those tend to, once again, be very high-end places that tend to be nonprofits oftentimes, or some of them are for-profit as well, but they're I think those are some of the models that have actually been pretty good, generally speaking. I'm not sort of advocating they can be very expensive, so maybe they should be. You see the numbers, but people have asked me if that's got to be the future, and I said, well, if you can afford it, and given kind of the savings behavior of most of us and the wealth distribution, I don't know that we're ever going to see that kind of model account for a large percentage of the marketplace going forward. But I think some people, they're really, the campuses I've toured, and maybe I agree there's some selection about places that invite you, but I was in one in Southern California about a year ago, and it was like 800 independent living units. It was really impressive. Their own, kind of, it was a nursing home and assisted living on campus, and it was gorgeous. We had delicious lunch and dinner at the restaurant there. Oh, where do I find my unit? It was great. So there's some nice models out there.
Some questions regarding the report cards or the future of the report cards. I totally agree that 5-star is easier for the customers to compare or to choose. It would be the situation that if the situation goes on, then people would be crowded for the 5-star compared to the 1-star, and then the 5-star will get better and better because they are attracted to healthy residents. while the most sicker and complicated, medically complicated residents have to be aggregated.
So we've
One
done,
time, then specialized.
yeah, no, absolutely. We did a paper, I didn't talk about it, but we published in Health Affairs with Tamara Konetska and Rachel Werner again, where we looked at kind of dual eligibles, and not surprisingly, they're more likely to end up at 1 star and 2 stars, so sort of the flip side of why they just don't have the access to those 5 stars. What's really fascinating, however, and we talked about this some earlier today, if I asked you how people choose nursing homes, what's the #1 factor, what would you suggest? It's
Availability of the beds.
Convenience, distance, location. It's actually not quality. And we've seen this in our data, but we've also seen it just as you ask people how do you choose or put together focus groups of families.
That's another measure of quality.
Oh, yeah.
I mean, I wouldn't, it's not really distinct from quality because it's a measure of ability to combine family care and institutional care, right?
Oh, absolutely, and I think convenience or distance, and the other part of this, I've been very critical of Nursing Home Compare, that if any of us wanted to go get a hotel room tonight near Amherst, we could see a lot of examples on the web, we could see pictures, we could probably see the room, we could look around. You can't see any of that on Nursing Home Compare. There's nothing about quality of life, it's all sort of these quality of care measures, there's no pictures of the room, there's nothing about amenities, there's no user reviews. Wouldn't it be nice if I could, I think that'd be really nice. CMS has been very reticent to add those. Just because they think it might add noise, it would, well, you know, it's just bad. I would love to read. That would be better than anything if I could read 10 reviews from family members that have had a person in there.
Yelp.
And there have been Facebook and Yelp, and some of this is happening separate of Nursing Home Compare. But I think that we could think about some real innovations. That why are these kind of private choice search engines so much better than maybe that's not surprising given it's a government.
Well, I mean, but don't you think, I feel like there's a lot of pressure of the nursing home industry to try to suppress that kind of thing from coming out. That's my opinion, but based on a lot of experience.
You don't want to see pictures of a lot of these places, I think. That's the problem. There hasn't been a lot of innovation.
I think, on the personal family experience side of this, I mean, when you have a mother or father and something happens and then you're faced with going to one of these for acute care kind of post-hip or something, then, it's like the social worker's like, okay, there's these 3 places, that's where there's an availability, and then you're scrambling and they're telling you have 24, 48 hours. I mean, the whole system is set up in a way that it doesn't help people make intelligent, informed decisions. I mean, they're just scrambling in chaos, And I'm a nurse, so I know, I feel like I have more ammunition when I'm going in to ask questions, to look to do these things. And I'm thinking, I cannot imagine what it would be for somebody who has no medical background or doesn't at all know what they should be looking at.
We had an instance with my wife's grandmother, who since passed away, but several years ago was visiting in Boston and got pneumonia and had to go into MGH and then needed to be discharged for some rehab. And so we asked the case manager if we could learn something about the SNFs, and she faxed a list of 100 places. And then I said, well, could you tell me something about these places? And so she then faxed me the same list again with handwritten numbers, like 127, 114, and said, I put the quality ratings. So I said, well, what are those quality ratings? I work in this area, I don't know what those are. What is this out of? And it was just really, and she was very reticent to give us any kind of recommendation. I think you're not allowed to steer residents in traditional Medicare. That's part of this, but you can certainly make recommendations, and I can tell you that you're allowed to sort of say that. And I'll tell you, one of the variables, in addition to convenience or distance, that's really strong towards influencing discharged patients towards a particular SNF is often our physicians round there. If you say that to it, we found if you're MGH and you say we round at Spalding, they're going to Spalding. It's just that's the connection there. So that can be very strong, but I agree with you. They're very reluctant to make recommendations, very reluctant to give data, and the data they give you is pretty bad, and so you're really stuck thinking about this, and very hard to go visit lots and lots of places. So. I should bring that, when I talk about reporting, I should bring that list. I still have it filed away. That's great. So or scan it or something. So anyway.
We have a final question, or? Well, thank you
Thank
so
you.
much.
Thank you. Just to make sure no one was awake, I kept knocking my mic out there. Sorry about that.